Assalamualaikum warahmatullahi wabarakatuh dan selamat pagi. I think we shall start. Right. Yang berbahagia Profesor Madya Dr. Mawadah Hazman, Ketua Jabatan Otorinolaringologi-Pembedahan Kepala Surgery Kepala dan Leher. A clinical pathological conference of interesting case, which is a face of mystery, unmasking the uncertainties behind a facial mask. So when you have a mass at the face, right, it is very important to treat accordingly, to manage accordingly, because you are not only dealing with the mass, right? You also dealing with the cosmesis and facial figure, right? So that's why it's very important for you to manage. So you have to balance between treatment, okay, and also the cosmetic, the destructive part and also the cosmetic part. I mean that you have to make sure that you have to deal with the mass properly. All right, so I think this is a very interesting case. The presenter will present on how to approach and how to deal with it, all right, to balance between these two. So without further delay, I would like to invite the first presenter, Dr. Theresa Chiu Hoong. She's a registrar in Otorinolaringology and Surgery Department. She will present on the clinical features of the case. I hope you will hear properly and also follow the presentation. All right, thank you. Dr. Theresa. Thank you, Farah, for the kind introduction. Very good morning to all the esteemed professors, lecturers, and specialists, my fellow colleagues, and dear medical students. Thank you all for your presence and kind support today. My name is Theresa, for those who don't know me. I'm a registrar from the ENT department, and I will start off this CPC session by presenting the patient's history and also clinical examination. This is Mr. T, a 15-year-old Chinese male who presents with left cheek swelling for the past 3 months. He described that the swelling was painless, rapidly increasing in size. However, there were no aggravating or relieving factor, and it was associated with one episode of spontaneous left-sided epistaxis with amount about 3 tissue soaked, fresh blood, and it spontaneously resolved. Other relevant negative, he did not have any nasal symptoms such as nasal blockage, rhinorrhea, and also hyposmia. No other symptoms to suggest local spread, be it anteriorly, posteriorly, superiorly, or inferiorly. So for anterior extension, we did ask about any skin changes or facial numbness, but this patient did not have it. Posterior extension, he did not have any limited mouth opening. Superiorly, he did not have any orbital symptoms as well, no intracranial symptoms. Inferiorly, there's no loose tooth or per-oral bleeding. No regional spread as well, there's no neck swelling. We did not have any symptoms of distant meds, such as shortness of breath or bone pain, no constitutional symptom. We do not have any past medical history. He's a fit 50-year-old Chinese male, no significant family history of malignancy. However, he's allergic to crab and prawns, whereby he will develop skin rash. For social history-wise, we did ask about any risk factors. This guy is single, he is non-smoker, did not consume any alcohol beverages. He's working as a shopkeeper. In particularly, we are asking for this kind of cases, there's no history of exposure to wood dust or any chemical agent. Moving on to physical examination, we can see that there's an obvious swelling over the left maxillary region, measuring about 6 × 6 centimeter. This is a big mass. And the border-wise, superiorly, it's extending to the lower orbital ring, medially until the nasolabial fold, and laterally until the zygoma. Upon palpation, this mass is non-tender, it's firm and lobulated, and it's fixed to the underlying structure. However, it's not adhered to the skin. On the side profile, he does not have any proptosis. Moving on to the important part, which is our nasal examination, the cold spatula test and anterior rhinoscopy were unremarkable. So I would like to focus on this nasal endoscopic picture showing the left nasal cavity. This is the middle turbinate. This is nasal septum. We can see that the uncinate process over here is inverted. However, there's no obvious fungating mass here. The sphenoethmoidal recess and also the olfactory cleft were normal.
Neck examination, oral cavity, and ear examinations were unremarkable. All his cranial nerves were intact. Oral cavity, we particularly looking at trismus, there's no trismus, and there's no fungating mass seen over the hard palate. Eye examinations were unremarkable as well. His visual acuity is normal, intraocular pressure is normal, there's no ophthalmoplegia. To complete our physical examination, the lungs, abdomen, CBS were normal, and regional, there's no axillary or inguinal distant lymph nodes palpable. So our provisional diagnosis for this case would be left maxillary sinus squamous cell carcinoma with a clinical staging of P3, N0, M0. The reason why we put P3 is because the superior extension is involving the orbital floor. We have a few differentials, for example, schwannoma, osteosarcoma, and also lymphoma. The reason why we think SCC is first because the presentation, this mass is rapidly growing mass, and SCC is the commonest maxillary sinus tumor, and it's common in this age group. This guy is 50-year-old. A few points against SCC is that there's usually fungating mass for SCC, but this guy, it's a smooth mass instead, and there's no constitutional symptoms as there's no other risk factors. Second on the list would be schwannoma, because we are thinking of schwannoma because it's a smooth surface, and the location of the mass is at the infraorbital nerve region. Points against is because schwannoma is a benign, slow-growing tumor. This tumor is fast-growing, and patient did not have any numbness. Third on the list would be osteosarcoma because of the rapidly growing mass as well, and it's common in this age group. But osteosarcoma over the head and neck region is very, very rare, and the consistency of the tumor is not bony hard. Last but not least, do not forget about lymphoma because it's common in this age group. It's smooth surface and it's quite common. However, there's no other lymph nodes palpable. So this is the end of my slides. Any questions from the floor? So without further ado, I would like to invite Dr. Fatima from the radiology team to discuss on further imaging. Thank you.
On the imaging part of investigation. So before diving into the imaging, which is the black, white, and grey, I just like to briefly talk about the differences between the imaging modalities that we have. So on top of the more readily available modalities such as radiograph and ultrasound, so these are the spectacular, the more detailed imaging, which is CT scan and also MRI. So some of the differences are CT scan are acquired from an X-ray, and MRI is using a strong magnetic field. So CT scan, as you know, is more readily available compared to an MRI. You can obtain an image or a full study in less than 5 minutes, whereas an MRI would take at least about 30 minutes. For safety-wise, again, for CT, because it uses X-ray, so there's radiation risk. And for MRI, because of the strong magnetic field, so our concern is about the patient has any mental implant within the body. And more importantly, for image quality, both imaging shows very good anatomical detail. However, MRI has a more superior soft tissue detailing, as for CT is slightly better for bony details. So we'll start with the CT scan. On your left-hand side is the coronal view of the city of the face, and on the right-hand side is the actual view. So these are some of the labeling on the normal side of the patient. The mass is here as seen in the coronal view. It is epicentered within the maxillary sinus here. There is, the mass is quite well defined. It is mildly lobulated. You can see that anteriorly and also posteriorly there is extra sinus extension of this mass extending to the pre and also retroantral space. So at this region where the walls of the maxillary sinus should be, we can see an erosion of the wall. You can appreciate better in the bone window. So in bone window highlights the bony details better. So as you can see, the anterior as well as the posterolateral walls are eroded. Some part of the zygoma is also eroded here. And I also like to highlight that the medial wall of the of the maxillary sinus is intact here. And this part here, small defect here is actually the inferior orbital foramen, which we can see that so on the normal side here, this is the normal inferior orbital foramen. So in this coronal view, in the bone window, we can appreciate that it is involved. So in this particular coronal slices, I'd like to highlight correlating with the nasal endoscopy finding. Remember that we don't really appreciate an intranasal mass, right? So if we look at the more posterior slice of this coronal view, we can see that this mass is actually exerting mass effect onto the nasal cavity. So this is the normal osteomeatal complex made out of a few anatomy. One of it is the uncinate process. So we can see that the uncinate process on this side is normal. It is mildly inverted. However, the mass extends up to this level. So radiologically, also we don't see any gross extension into the nasal cavity, more so just mass effect externally from the maxillary sinus. Next, we will quickly look at the MRI images. So as mentioned earlier, MRI shows a more superior soft tissue containing. So you can appreciate the muscles and fat. This is a T2 rated, T1, and this is post-gadolinium injection, but this is fat suppressed. So you don't see the fat as well anymore, and it highlights the mass. So it is intermediate signal in T2, quite homogeneously iso-intense to the muscle in T1 rated images, and you can see heterogeneous enhancement. And we can also appreciate the more lobulated appearance of the mass, with not so much of infiltration toward the surrounding structure. It has quite a nice smooth margin. Again, so this slides are just to show the superior extension of the mass, which you have not touched. So superiorly, we have the orbital structures, which clinically we were suspecting involvement, right? So other than the anterior and posterior wall, actually the floor of the orbits are also eroded here, as you can see. And inside the orbital cavity, the closest structure that we are concerned of are usually the inferior rectus muscle, which is on this side, on the affected side. So, however, we have an MRI to actually further look for another layer, which so we know that the bony wall is gone. However, there is another layer of the outermost layer of the orbit, which is the periorbita. So it is most well appreciated in a T2 rated image, as we can note here. It is outlined by this low signal T2 structure here. So which you can also actually still appreciate on the affected. So on a more anterior cut of this coronal view, again, we can see that the mass actually is grossly abutting, or rather bulging into the orbital cavity. But however, there is still a thin layer of periorbita, which is still intact, and it is not, there is also no streakiness of the extracoronal fat. So with our imaging, we can try to further narrow down the few differentials that we have come up with. So I think a sinonasal, or rather a maxillary sinus SCC, is still at the top of our list. Next is osteosarcoma from the CT. We do not see any osteomatrix or any periosteal reaction. For schwannoma, as I showed, the epicenter is actually within the maxillary sinus, just might be involving the inferior orbital foramen, not exactly at the foramen. And for lymphoma, usually we depend on the MRI signals. So lymphoma, it is a high cellular mass, right? So we would anticipate the T2 signal to be lower. And I did not show this, but there is no significant stated diffusion on the MRI. That's all from me. Thank you so much for the first presentation just now, and also the radiological discussion.
Is there any question before I proceed to invite the next presenter, our speaker? With the 4 master students, it's very important to know which one, T1, T2 kan, dia tanya dalam exam eh. So you have to know about it. So this presentation is very important, okay? So please concentrate on the presentation, because at the end we have a quiz, and also the presenter Mr. Afif prepare a prize for you. Okay, so nanti kita ada Kahoot dan juga pemenangnya akan mendapat hadiah. Okay.
I have a question to Dr. Theresa. So Dr. Theresa has presented the provisional diagnosis and differential diagnosis based on the clinical history. So now that you have got the imaging findings, do you want to further narrow down your provisional and differential diagnosis and give us the points for and points against based on the clinical history, physical examination, as well as the radiological findings? From here.
Thank you, Prof. Mawa, for the Viva question. Okay, so for my list of differential, I wouldn't sway too much after looking at the radiological results. I would think that this is more likely a benign tumor instead of a malignant one. Maybe my second provisional would be a schwannoma instead, based on the MRI, because it looks like a well-encapsulated tumor with very local extension. It's local extension. So my answer would be, I will put down on schwannoma. Thank you, Prof.
So much, Theresa. So without further delay, I would like to invite Dr. Afif to present further regarding the case. Okay.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good morning, distinguished professors, Professor Prof. Mawadah Azman, Head of Department, Professor Salina, Prof. Dina Hashim. Yeah, my name is Dr. Afif, and I'm the specialist in charge of this case. So I just like to share my thoughts or diagnostic dilemma in managing this case, which leads to certain uncertainties. Okay, so to recap, we have a 50-year-old Chinese male with a rapidly enlarging left maxillary mass. Okay, there's no intranasal tumor from endoscopy. He has a normal orbital function. However, there's erosion to the anterior wall of the maxilla and the orbital wall. Okay, so the tumor is very, the anterior wall is already eroded. Just underneath the skin, there's a tumor. So the first thing that I have in my mind is how to take the biopsy. So how many of you will do an open biopsy? Can you put up your hand? No one wants to do an open biopsy? Okay. How about endoscopic biopsy? So we only have 3-4 seconds in the hall here. Okay, right? So it's very tempting to take a biopsy using an open approach because the tumor is just underneath the skin. Okay. However, when we do such procedure, even though we can get a big good sample, if the tumor turns out to be malignant, it can cause settling of the tumor can fungate out the skin, and during your definitive surgery, you have to include the skin as part of the margin, and that means you have to reconstruct using a quick tissue transfer. So endoscopic is always what we prefer. It is minimally invasive. You can avoid scar to the face. Okay? However, in this case, it is not seen endoscopically. So we decided to put the patient under general anesthesia and perform endoscopic medial meatal enterostomy So if you look into this picture, so this is the schematic diagram of the middle cabinet. We do uncinectomy and we widen the meatus, middle meatus, okay, and we even cut the interior turbinates, the posterior part, and from this procedure, we're able to access the tumor from medial. So we can avoid scar to the skin and we can get a good chunk of sample, okay, for the biopsy. And guess what is the histology report? It is reported as spindle cell neoplasm. Okay, spindle cell neoplasm. So the problem with spindle cell neoplasm, it has a broad differential diagnosis from benign to malignant. Okay, we have to really careful interpret this result because we do not want to miss the high-grade sarcoma which is deep inside. So which means we have to take the whole chunk of the tumor by means of maxillectomy. Okay, but now it leads to another question. Okay, how much should we check? Can we preserve the orbit and how to reconstruct the face? Okay, so can I get a postgraduate lah? Boleh tanya Prof? You can ask. Can we have one of the postgraduate to propose surgical management for this patient? Any ENT postgrad? This is a golden opportunity. Okay. Can we have exam tour? Can we have semua tunduk kan? Masa ni tak waduk kan? Okay. Can we have Farhana? Farhana, would you like to answer, Farhana? You go to the mic. So Farhana is our registrar in Otorinolaringology.
Assalamualaikum and good morning. For this case, I'm thinking of at least we do the subtotal maxillectomy and also with because based on the imaging, the tumor already involved the orbit. So I'm thinking of the orbital reconstruction also for this patient.
The reconstruction means you want to
Accentuate the orbit
accentuate the orbit.
and reconstruct.
Okay, all right. You have another opinion by other postgraduate. So bear in mind, the histology that we have is spindle cell neoplasm. It's not confirmed malignant yet, squamous cell carcinoma. So I agree, we can do a partial maxillectomy. So if you look back into the tumor, it is located superior, anterior, and lateral. So with this, instead of performing a total maxillectomy, we can do a subtotal where we preserve the palate, okay, and our bony cuts, we can mainly at the zygoma and at the lateral orbital rim. Okay, and the anterior part and the posterior part actually is the tumor is well demarcated. With regards to the orbit, first we have to remember that the histology is not final. The orbit is functioning as well. And from the scan also, the periorbita is preserved. So I think it's not justified to do an orbital exenteration in this case. So we preserve the orbit. Okay. So this is the incision that we perform. It's a Weber-Peterson incision. And in this case, we even extend the incision laterally. So we raise the flap and you can see the tumor is easily, not that easy, I mean like it's not attached to the skin. So if we can, even though the skin is pinchable, it's very stretched, the skin is stretched. So we were even considering to put a flap because we might thought that the tumor is close to the skin, but actually we can separate the soft tissue from the tumor. And I think this video explained very well.
This is an orbital flap Orbital fat is the anterior part of the medulla we remove. So this we pull this, right? So and then this the whole area, these are from here to here until belakang, that's the orbital floor. Okay, so it's quite big defect lah of the orbital floor from there until there. So this is really like lah. So this one need reconstruction. If you don't reconstruction, then dia akan jatuh macam tu. Okay, and then we already open up. Okay, these are all the tumor. Mana tumor tadi? So we cut this part and we cut this part. The zygoma part and this part. So this is the tumor. Okay, if you want to orientate, boleh lah. So that's where the tumor was lah. Okay, the zygoma part, okay, kita remove. This is the orbital floor. Dah resolve, dah tak ada dah. So we take out that one. So clear.
Okay, I think you can guess the voice. The voice is abroad. Okay, so this is the tumor that left, that was taken out. It was about 4 times 5 centimeters, and we are left with this defect. Okay? So with the regards to the reconstruction, I would like to invite Associate Prof. Dr. Syed Nabil to discuss about the mid-facial defect reconstruction. Thank you.
Assalamualaikum and good morning. Thank you, Mr. Afif. So we've been presented with a disease that is at the mid-face with an unconfirmed pathology, and now we have resected it and we need to reconstruct the area. So let's first look to what is mid-face. Mid-face is an area which is at the middle of your face, bordered by probably from the lower eyebrow up to your margin of the upper lip. So it's the whole center of the face. This is quite a complex area. If you consider the mid-face, it contains the organs for your vision, your eyes. It contains organ for your smell. It contains organs for your chewing, the teeth. So it is an area which is small but highly complex with multiple functioning things within that area. Another thing that is important in mid-face is it is at the center of the face, so it represents your identity. So any reconstruction around the face, you want to be as normal as possible so that the patient face won't change much. So when we talk about mid-facial defect, the size and complexity will definitely impact the function, aesthetic, the identity, and definitely will affect the quality of life. Depends on the functional and aesthetic. When we discuss about the defect around the mid-face, it is important to have a classification so that we can plan the reconstruction and how we can replace the missing tissue. The most common reconstruction classification of the mid-face that is used is by Brown's, which is considering the vertical loss, how much tissue is lost vertically, and also how much tissue is lost horizontally. So if you look at that classification, we have 5 vertical classification for mid-face or maxillectomy defect. The first one is low maxillectomy. So that one is just involving the teeth, usually not causing any communication with the maxillary sinus. So the reconstruction is generally just replacing the teeth with dentures or operators. With low maxillectomy, then it involves the sinus. So this one definitely you need to cover the sinus to maintain the integrity, and that one might need a obturator type of prosthesis. With type 3, that one including the orbital floor, but you maintain the orbit. So this is a total bone defect, which is complex in its structure and usually might need a free flap. Higher up, if you include the orbit exenteration, as we discussed, with or without, it will be class 4. Class 5 is without palate involvement, a bit higher up. You look at that image. And class 6 is when it involves the nasal complex. That classification, type 1 to type 6, can be combined with the horizontal classification. Example, if you have type 4 with half of the maxilla being resected, you have to classify it as 4B. If it is total maxillectomy, then it can be 4D. So it depends on also the palatal defect, because it will decide on the reconstruction of need of the patient. So when we look at any cases, we need to consider how much is of the defect, of course, because the options are quite variable. You have from a free flap, a local flap such as temporalis flap. You can use a titanium implant for a complex structure. You can use a plastic obturator to close the space. So there's a range of options for mid-face. What we need to consider is, of course, the defect size. How big is the defect? Where is it located? Does it involve the eye? Does it involve the nose? Any cavity that needs to be closed, such as the oral cavity, the sinus cavity, or the nasal cavity. And what we have here is an issue, whether it's malignant and benign, because the different treatment, especially involving a radiotherapy, will affect the decision on the reconstruction option. So in this case, as shown by Mr. Afif, it is a plus 5 defect. So plus 5 is there is an orbital floor involvement, a zygoma involvement, and part of the anterior maxillary sinus. In this case, the good thing is the orbits were decided to be preserved. If there's an orbit involvement, orbital accentration, then the complexity is different and the decision will be different. Another thing of an issue here is there's a possible radiotherapy need. So when there's a possible radiotherapy need, the consideration also needs to take that as part of the classification options. And we decided on titanium reconstruction. Why? Because one, the defect is bone only, the soft tissue are preserved, the orbit are not accentuated. So there's two options for bone reconstruction, either a free flap with a bone, or in a complex shaped bone, titanium would be one of the best options. What we aim in a reconstruction of the orbit and the midface is, in this case, is most importantly is to prevent orbital dystopia. As shown in the video, when there's no flow of orbit, the eye might drop down, so you might have a vertical dystopia. When you have a vertical dystopia of an imbalanced eye level, then you might have a vision changes such as double vision. So orbital dystopia is the main aim of the reconstruction. Second aim is to reduce cheek asymmetry. As shown in the defect picture before, the zygomatic bone prominence are included in the resection margin. If you imagine your face, the most prominent part of your face at the midface is the zygomatic bone, which is the cheek prominence. This part are part of the resected margin, and if we can, we want to maintain some form of symmetry. And finally, of course, you want to get a good eye motility. Without a good eye motility, if there's a restriction in one eye movement, again, you'll have a double vision post-operatively. So how do we plan a reconstruction? There's few options, but when we decide to do a titanium reconstruction, the first thing that we need to do is we have to use the CT scan that was taken before. So that image, we have to extract the DICOM data, the DCM data, and convert it to a stereolithographic data, we say STL data. So once you have the reconstruction of the CT scan in your computer, then you send it for 3D printing. So 3D printing of the skull, in this case, what we do is we mirror image the right face to the left of the patient. Why we do that is because the right side is normal. So we mirror image it and then print the skull. Then you will have a normal anatomical shape of the left side of the face not affected by the tumor. So, and you can see the image there. That is the 3D printed skull of the patient. And we plan for titanium mesh reconstruction of the floor on orbit and also the zygoma. So we bend the mesh pre-operatively so that it will be fitting and follow exactly the pre-operative anatomy or the normal anatomy of the patient. Okay, so you can see the image there. The titanium plate is bent to adapt the normal anatomy, and following that, the titanium is sent for sterilization. So in this case, following the resection, we have to consider a few things. One, we must reconstruct the floor orbit exactly where it should be. So that has been bent nicely. But how much of the titanium plate should be kept? Titanium is biocompatible, we know that. However, it is sometimes sensitive to area which is the soft tissue is thin. So you use titanium for any limbs orthopedic fracture, but it's covered by good tissue and muscle. In the face, if you look at the image, you can see the flap which is raised. The cheek skin is thin. So when we put back the plate in, you must consider the scarring and the constriction of the soft tissue. We can reconstruct the bone, but the soft tissue consideration covering the bone must be considered. We don't want the plate to be exposed, especially with radiotherapy. When there's a radiotherapy, the skin will further shrink and it will cause further risk of exposure. So what we've done when we saw the defect is prior to the to sending the plate in, we've bent the plate to be a bit larger than the planned defect because the margin of the surgery was not clear. We know, but we're not sure how much we want to remove. So we bend it a bit more. But intra-op, we've removed a bit of the zygoma part because of a concern of radiotherapy exposure post surgery. So if you look at the reconstruction picture there, it is a bit smaller than what we bent, and we bend it in to prevent too much prominence to the cheek side. So what do we see after the surgery? So first thing is the orbit level is exactly the same. So it means that the reconstruction of the floor orbit was exactly as planned. You can see the level of the eye by looking at the interpapillary line between the papilla of two. You can compare the papilla between the two eyes. So that is exactly the same. So what it means is we prevented dystopia, the main aim of the surgery. Second aim is, of course, to get a good eye movement. In this patient, the eye motility are maintained. Okay? So the functional of the eye is again maintained. What we sacrifice in the reconstruction is, as we've discussed, is the cheek symmetry. Because rather than have a good symmetry with the plate exposure, we've decided that we reduce a bit of the prominence of the cheek in view of possible radiotherapy. So in this case, if you look at the progress, 1 week to 8 weeks, the eye level maintained the same, but you cannot predict the soft tissue response. In here, there's a bit of a scarring and shrinkage of the soft tissue. So the prominence of the cheek is slightly less, which is seen there, but it's a bit more prominent from this view. So if you look from above, preoperatively, it's prominent. Immediately 1 week after, it's not prominent anymore, but it's a bit shallow. But the eye level is exactly the same. And after 8 weeks, you can see the shallowness there. So all in all, we've achieved most of the reconstruction aims of the surgery, considering the complexity of the defect. At the end, patient maintains his eye function. Patient maintains the smell function. Patient maintains the chewing function, but the aesthetic is slightly affected, but in most cases, patient identity is still maintained. So I think we've achieved a good reconstruction. All right, thank you.
Prof. Right now, it's very interesting to see the reconstruction part, because before this I mentioned that we have to weigh between the removal of the tumor and the reconstruction part, and also preserve also the function, right? So just bear in mind that in this case, we managed with the diagnosis of without malignancy at that time. Okay, so that's why, in previously, Mr. Afif already showed what's the surgery has been done. For the set of master students, the intranasal mass, we do endoscopically. Okay, we removed endoscopically, so we inspect the lamina papyracea is intact, but only the medial wall of the floor of the orbit is eroded. So that's why it need to be reconstructed and removed. Okay, so we like to know more about the histopathological examination, right, for this patient. So I would like to invite Dr. Aziani Yahya, the anatomical pathologist from Department of Pathology, to discuss further on the HPE of this patient.
Okay, Assalamualaikum and a very good morning to members of the floor. Okay, so I'll be discussing on the histopathological examination of this patient specimen. Okay, this is the clinical history written on the request form. 50 years old, Chinese male with left cheek swelling since September 2025, increasing progressively in size. CT scan showed heterogeneously enhancing mass epicentered within the left maxillary sinus, with a dimension of 4 cm, with breach of the anterior maxillary sinus wall, involvement of the left infraorbital vermin, and breach across posterolateral wall of maxillary sinus, extending into retroankle tract. We had a biopsy taken, okay, in November 2025, which we concluded as a maxillary tumor consistent with spindle cell neoplasm, with differential of solitary fibrous tumor and fibromyxoid spindle cell tumor. So he underwent left subtotal maxillectomy, anterior ethmoidectomy, with preservation of the palate and orbital floor reconstruction. So I'll be discussing on the main specimen of the patient sent to us in December 2025. Okay, so it consists of 6 specimens. Okay, from the left lateral nasal wall, left posterior wall, maxillary sinus, mucosa of the superior wall, left maxillary sinus, mucosa of the floor of the left maxillary sinus, and then tumor from the medial wall, and also tumor from the left maxillary sinus. So specimen F is the main bulk of the tumor, so I'll be concentrating on specimen F. Okay, so this is the main bulk of the tumor, labeled as tumor from the left maxillary sinus, measuring about 43 millimeter in the greatest dimension. The cut section show a fairly circumscribed mass with firm grayish white surface. Okay. The tumor grossly involved the medial, superior, inferior, and anterior surface, and is less than 1 mm from the lateral and posterior surface. So we sectioned the specimen and submitted it in 15 sections. Okay, so this is what we see under the microscope. Okay, so it is a partially encapsulated and rather circumscribed tumor, composed of variable cellularity. Okay, and the tumor cells is mainly spindle to ovoid cells. You see here, cellular tumor. Okay, composed of spindle to ovoid cells. So they are arranged either haphazardly, or they are forming short ill-defined vesicles. So the tumor cell itself, it displays vesicular to hyperchromatic nuclei without prominent nucleoli, and it has indistinct pale moderate cytoplasm. Okay, and we see this branching vessels. Okay, so we describe these vessels as hemangio pericytomatous like vessel. Okay, so it describes this branching dilated staghorn shaped vasculature. Okay, so we see all these vessels throughout the tumor. Okay, and then the tumor also they show hyalinized and collagenous stroma. Okay, again showing you the tumor is cellular, composed of spindle cells, and there is this scattered branching vessels, okay, or staghorn shaped vessels, okay, with a variable amount of hyalinized and collagenous stroma. Okay. In areas, actually in focal areas, the tumor is more hypercellular, okay, and we see this herringbone pattern, which is describing the arrangement of the cells. They are forming this crisscross pattern, okay, which resemble the bone of the herringfish. Okay. So this is the crisscross pattern. Okay. Usually we see this pattern in a fibrosarcoma. Okay, so when seeing this patient at this pattern, so it raised a concern of any malignant transformation within the tumor. This is to show you the tumor has increase in mitosis. Okay, so this is in one high power field. We can see about 3 mitosis here. So we counted 10 high power field, okay, under microscope, and we can see up to 7 mitosis. Also, tumor has areas of necrosis. Okay, so this is necrotic area, okay, and this is the viable tumor area, and this is the branching vessel. So all these areas are necrosis. However, the necrotic area is amounting to less than 10% of the tumor volume. Okay, there are also areas of fat infiltration as well as skeletal muscle infiltration. So this is skeletal muscle, and you can see the tumor has infiltrated in between the skeletal muscle. There was no marked cellular pleomorphism, no bony invasion, and no lymphovascular invasion seen. So grossly, the tumor has involved the medial, superior, inferior, and the anterior margins, and this is less than 1 mm from the lateral and posterior margin. So we proceed with the immunohistochemistry. Okay, so CD34 is diffusely positive. Okay. And we did CD7. This is to show you the proliferation index of the tumor. So it is about 30 to 40%. Okay, so there's a mild increase in the proliferative index. Okay. And we did some immuno to exclude carcinoma by doing the cytoferritin, which is negative. SNA is to exclude any smooth muscle tumor. Okay. ENA again is for carcinoma, okay, which is negative, and S100 this is to exclude sarcoma. All negative. Okay. Based on the morphology and the immunohistochemistry, so we concluded that this is a solitary fibrous tumor. Okay. But with focal sarcomatous transformation, and the risk stratification for development of metastasis. This is taken from the WHO classification of tumor. Okay, so it takes into account patient age, mitotic count, the size of the tumor, as well as presence of necrosis. So the patient is at low risk. Okay, so this is in general what is solitary fibrous tumor. It is a fibroblastic tumor characterized by prominent branching, thin-walled, dilated staghorn vasculature, okay, and NAP2 STAT6 gene rearrangement. It can show wide range of histological pattern, and under ICD-10 coding, it is placed on the neoplasm of uncertain behavior of connective tissue. It can present at any anatomical site, up to 40% in the extremities and the deeps of tissue, 10 to 50% in the head and neck. Okay. In the head and neck, the most common would be sinonasal tract and the orbit, okay, followed by oral cavity and the salivary glands, and then up to 50% can present in the trunk. Mostly, the tumor present as a slow-growing painless mass, more common in female with peak between 40 to 70 years old. The genetic hallmark is the paracentric inversion involving chromosome 12q, resulting in the fusion of the NEP2 and STAT6 gene. Okay, in morphology, so grossly it is a well circumscribed mass, typically measuring up to 10 centimeter, or it can be larger, with nodular 10 to reddish brown fat surface. Under microscope, you can see this haphazardly arranged spindle to ovoid cell with indistinct pale eosinophilic cytoplasm within variably collagenous background stroma. And then presence of these hemangio-pericytomatous blood vessels, or the staghorn shaped vessels. Often the tumor have low mitosis and without marked nuclear pleomorphism or necrosis. Again, it has wide histological spectrum from a low cellular tumor with abundant keloidal type collagen to a highly cellular tumor with little to no intervening stroma. And we can see some slight change in it. Okay, by immunohistochemistry, it shows strong and diffuse CD34 stain with a nuclear STAT6 staining. Okay? However, in our lab, we don't have this STAT6 immunohistochemistry at the moment. Tumors with high mitosis and increased cellularity, ectopia, necrosis, and infiltrative growth have traditionally been termed malignant solitary fibrous tumor. However, this new risk stratification model more accurately predict prognosis. So these are some of the differential diagnosis, okay, especially after the biopsy. So we'll be thinking of this differential diagnosis of synovial sarcoma, but it will be, because synovial sarcoma, it can exhibit the hemangio-pericytoma-like vasculature. However, CD34 would be negative. STAT6 also would be negative. Leiomyoma, okay, this is also spindle cell tumor. However, the muscle staining would be positive and CD34 would be negative. Just now there's a raised concern of squamous cell carcinoma. Okay, so spindle cell carcinoma is also will be differential. However, it shows more pleomorphism compared to SFT, and the cytoferritin would be positive in spindle cell carcinoma. Schwannoma, usually we see this zonal pattern of antennae A and antennae B, which is the hypercellular and hypocellular area, which is not seen in this patient. And S100 will be positive. Other differential include the FSP, dermatofibrosarcoma, okay, which lack the branching vasculature. These are among the differential. Okay, moving on. For prognosis of SFT, recurrent is in 10 to 30% of cases, up to 40% recurrence reported after 5 years. Okay. Various features have been reported to correlate with the metastatic or recurrence potential. So this include mitotic rate, okay, more than 4 mitosis per 10 hypophil, tumor size, necrosis, patient age, cellularity of the tumor, nuclear pleomorphism, and the site of the tumor. The FNC-LCC grading system for sarcoma is not applicable to this tumor. So currently, the risk stratification models are preferred over the normal anatomical staging. A bit on the risk stratification in solitary fibrous tumor. So this is essential for predicting recurrence and managing follow-up in this patient. Okay. This tumor, they can behave aggressively regardless of the initial benign appearance. So development of these risk models, okay, has resulted in improved prognostication over the traditional benign malignant distinction. Okay. The most widely used system is the Denico scoring model. Okay. So this model, they classify tumor into low, intermediate, or high risk based on these features. Okay, mitotic count, either it's more than 2 mitosis. Okay. The age of the patient, size of the tumor, okay, stratified by 5 centimeter cubes, and a subsequent refinement include necrosis as the fourth variable. Okay. And this model has been validated for both thoracic and extra-thoracic SFT. So this is the paper which explain about this risk stratification, okay, by Elizabeth G. Denico in 2017. Okay, so this is the risk stratification used. Okay, so age, whether patient is less than 55 or more than 55. Okay, the size of the tumor, okay, less than 5 cm, 5 to 10, 10 to 15. Okay, mitotic count, okay, whether 0, 1 to 3 or more than 4. And tumor necrosis, less than 10% or more than 10%. So the patient is less than 55, tumor is less than 5 centimeter, mitotic count we found about 7, okay, so that put patient into more than 4, and presence of tumor necrosis but less than 10%, so that's 0. So total score is 2, so patient is at low risk. Okay, thank you.
Thank you, Dr. Ajani. We always call pathologists as the temple of truth. The truth is unexpected. So maxillary sinus fibrous tumor with sarcomatous transformation. It is an exceptionally rare tumor, and to have a sarcomatous, a focal of sarcomatous transformation also, it's rare. And this tumor does not fall under the dichotomy of benign and malignant category. Instead, it has a spectrum of biological behavior, and the pathologist uses this clinical criteria to predict the behavior. And there's no standard guideline on how to manage this, because the one that we have is mainly for SCC, squamous cell carcinoma, and even for SFT, it does not follow the sarcoma guidelines. Okay, so this leads to another headache, okay, for the uncertainties. Okay, do we need to give RT this patient, radiotherapy to this patient? Does the patient requires chemotherapy, and how do we follow up this case? So we brought this case to discussion with the oncology team in our onco combined discussion clinic, and because the margin is close, so I think even though the DEMICO criteria is low, but we still advocate for adjuvant radiotherapy. However, giving radiotherapy to that region will cause radiation retinopathy. So patient will get blurring or loss of vision, and also diplopia. And after a long discussion with patient, unfortunately the patient refused for radiotherapy. Chemo is only reserved for distant metastasis, and this patient requires a long-term follow-up. So I've been following this patient for the last 4 months. There's no obvious recurrence. This is the scope, 70-degree scope from the left nostril using a 70-degree rigid scope, and we can see that the maxillary sinus is well epithelialized, and the implant is already covered by the epithelium. Okay. Right. So my take-home message: maxillary solitary fibrous tumor is rare. It can exhibit a spectrum of biological behavior ranging from indolent to malignant behavior. Endoscopic biopsy is preferred approach to avoid tumor seeding of the facial soft tissue. The initial spinal cell biopsies are prone to sampling error and may miss focal high-grade malignancy. So preoperative planning must carefully balance between the organ preservation and also oncology safety. And the last but not least, as Prof always remind us, we have to do multidisciplinary discussion, okay, whenever we're facing a lot of uncertainties in our clinical management. So with that, thank you very much. Right. So is there any question? Yes.
Hi, good morning.
Yeah, Prof.
Thank you so much for the Otorinolaringologi department for inviting us for this really interesting case. I have a question for you, Mr. Afif. I'm just wondering what your thoughts are regarding ultrasound-guided biopsy, TrueCut biopsy of this mass for this patient as a feasible alternative the endoscopic. For context, I just did a quick Google search. One paper reported for head and neck SCC, the risk of seeding after true cut biopsy is 0.0011%. But I'm interested to know what your thoughts are.
So the ultrasound guided fundamental aspiration or biopsy to the neck, I think the risk is low. But with the face, when the skin is very thin, even though the risk is low, we try to preserve the soft tissue of the skin as much as possible. So that's just my thought. So we were considering ultrasound guided biopsy initially, and my thinking was that there's a lot of bony area in that region, the orbit, the lateral floor, the palate. So I thought there would be a lot of artifact. I'm not sure during the ultrasound manipulation. That's what my concern. And the concern is we try to preserve the skin as much as possible so that it can help us with the definitive plan and the reconstruction later. So maybe if other professors give point of view, but that's I think we had this discussion before. That's the main thing. Yeah.
Any further question? To me, if let's say the tumor is visible in endoscopic during in clinic, we can take in clinic as well. So, but this patient, there is a mucosa overlying the tumor at that time. So that's why, and then it's just the medialization of the wall, of the medial wall of the sinus. So that's why we didn't take it as well because of. But considering, if let's say I want to ask for, if let's say we can do a biopsy, like a CT guided biopsy through the nasal cavity to the mass at the center of the mass, is it feasible? That is through the nasal cavity, because we don't want to go to the nose now, to the face.
Like transnasally through the nasal.
Yeah, but going to the center of the tumor, because we don't want any problem, because of we don't want any misdiagnosed. We don't want to take any inflammatory tissue, right?
You mean for a mass of this location?
Yes.
I don't think it's been done. I think generally it tends to be done for if we have to traverse subcutaneous fat, skin, or even sometimes I've seen buccal fat. Those are considered okay, because actually those structures are seen easily quite well. But if we have to traverse, I'm not sure. Yeah, I'm not sure it's commonly done for transnasal in that sense lah. Yeah, because I think for us, like the fat planes is, if the fat planes are clean, we can see any critical vascular structures. I understand, those kind of structures that we will try to avoid. Yeah.
Thank you. So that's the another question with that. So that one is one of the topic of the systematic review later. All right. So we go to the Kahoot, I think. Yeah, because of we are behind time. Can we start? Can I ask Mr. Afif to moderate it?